We often hear about amazing healthcare breakthroughs, right? But what actually happens when the system itself just can't deliver them effectively?
Hmm.
When those crucial resources, equipment, staff, beds, aren't readily available, it leads to things we all recognize, like waiting lists, delayed
Sort of
treatments.
frustration we all encounter in some way.
Exactly. So today, we're going to dig into exactly that, incorporating resource constraints in health economic evaluations.
Hmm.
We'll be unpacking a really insightful framework from a recent paper. It really sheds light on how overlooking these limitations impacts healthcare decisions and, well, ultimately patient outcomes. Okay, so let's start with the basics. What's the fundamental problem this paper is tackling?
Well, it kicks off by pointing out a huge assumption often made in traditional health economic
How it
evaluations,
is.
that all the necessary resources, think medical equipment, skilled staff, everything are just there, instantly available whenever needed.
Right, almost like a perfect world scenario that doesn't always match reality.
Precisely. And what's really the eye-opener here is realizing the consequence of ignoring these constraints. The paper argues we end up operating with suboptimal information,
Suboptimal information,
meaning we're essentially making critical healthcare choices,
Mm.
like adopting new technologies, without fully understanding if we can actually deliver them efficiently. It's a bit like planning a road trip, assuming infinite fuel.
And the COVID-19 pandemic really brought this home, didn't it? The paper uses that as a stark example.
Absolutely. The lack of masks, ventilators, even just enough trained staff,
Mm.
it showed everyone very clearly how damaging resource constraints can be across the board.
It wasn't just a theoretical problem then. It was very real, very immediate.
Exactly. So to help us get a better handle on this, the paper breaks down constraints into three main types.
Okay, what are they?
First, you've got single-use resources. Think pharmaceuticals, disposable masks, things you use once.
Got it.
Then, reusable resources. This is where things like doctors, nurses, hospital beds, or big equipment like MRI scanners come in. Using them for one patient means they're unavailable for another, potentially causing delays.
Right, the classic bottleneck issue.
And finally, there are patient throughput constraints. These basically limit how many patients a facility or system can physically process in a day.
And crucially, these aren't just neat categories for researchers. The paper stresses they have real, tangible impacts.
Oh, absolutely. We're talking about delayed treatments, which isn't just inconvenient. It can actually worsen a patient's condition, sometimes tragically increasing mortality rates.
That's serious. What else?
Well, you also see resource diversion, pulling staff or equipment from one area to plug a gap in another, and task shifting, like training nurses to give injections, usually done by specialist doctors to free them up.
So shuffling resources around to cope.
Yes, and zooming out a bit, this isn't just an operational headache. It quickly becomes an ethical issue, too.
Well,
Because when resources are genuinely scarce, systems are forced into making incredibly tough decisions about who gets treatment and when. Prioritization becomes unavoidable.
really difficult choices. So the paper doesn't just diagnose the problem, it offers a solution.
It does. It proposes a pretty comprehensive framework to address this gap in evaluation.
What does that involve?
It outlines practical steps, everything from deciding the scope, are you looking at one hospital or a whole national system,
Yeah.
to picking the right data sources and then estimating the real impact on things like quality-adjusted life years, QALYs, and of course, costs.
So a more realistic way to measure value.
Exactly. It's designed to give decision makers a clearer, more accurate picture. It also contrasts different methods, quantitative approaches that explicitly model the constraints versus qualitative ones, which might be less precise but still useful if data is scarce.
And they have a case study to illustrate this, right? About lung cancer testing.
Yes, a really powerful one. It looks at capacity constraints in ALK mutation testing for non-small cell lung cancer.
And what do they find?
They found that limitations in testing capacity, maybe not enough machines or staff or efficient processes, significantly impacted patient outcomes. It wasn't just a minor hiccup.
How significant?
Well, the analysis showed these constraints led to an estimated annual net monetary benefit shortfall. That's basically the value lost to the health system and patients of around £5 million.
It's 5 million lost annually just from testing capacity issues.
Yes. And what's particularly interesting is that while the overall benefit took a massive hit, the impact on the usual efficiency metric, the incremental cost effectiveness ratio, or ICER, was actually smaller.
So the standard measure didn't quite capture the full economic pain.
Exactly. It highlights where the real loss was felt in the overall value delivered, not not just the cost per QALY gained at the margin. So I think this deep dive really underscores something important. Explicitly factoring in resource constraints isn't just, some minor methodological tweak for
It
academics.
sounds essential.
It is essential if we want to truly understand the full value, the full impact of bringing in new health technologies. It's about seeing the complete picture, warts and all.
So wrapping this up, what's the key takeaway for you listening? It's really about recognizing that healthcare decisions don't happen in some ideal world of unlimited resources.
They happen in the real world with real limits.
Right. And it's about making sure we consider every piece of that puzzle, every constraint, so we can make the genuinely best choices for patient care and for the efficiency of the whole system.
Well said.
And here's a final thought for you to maybe mull over. Thinking about your own local healthcare system,
hmm
how might actually incorporating these kinds of constraint considerations change how they prioritize new treatments or services? Something to consider.